请问那个Professor Chu 上线了吗？嗯蒂凯，你要不要联络他？还是我们请那个微乳联络他？
所以这样吗？
因为我也是没有看到，我也是没有看到他上线。
这样吗？
嗯。
我收到他的信说他现在灯不见，我请他再试一次，稍等我一下。
好的。
OK， 那我就先不动了。
好。
好。哦，这样可以吗？
应该进来了。
Hello.
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 Yeah.
Hi, Wei-Ju.
Hi.
Hi,
It's
Dr.
nice
Lee.
Hello. It's nice to meet you. Yeah.
Hi.
Hi. You.
Jong-Ling, nice to see you.
Nice to see you. Yeah. We will begin right now. Yeah. You have some problem to online?
Yes, I did, but it finally is okay now, I hope.
Okay. Yeah. It's very late at Los Angeles. Yeah.
About 9:35, not too bad.
Okay. Yeah. Okay. Okay. I will introduce Helena Chu. She's an old friend and a good friend of Taiwan. Okay. Professor Chu has been on the faculty of Department of Neurology at the University of South California, Keck School of Medicine since 1981. She's currently McCarroll Professor of Neurology and Gerontology, and since 2003, Department Chair. And the department provides comprehensive outpatient and inpatient service for the full spectrum of neurology conditions and conducts medical research and mentors future generation of medical professionals. Dr. Chu earned her bachelor degree in chemistry and a medical degree at the Johns Hopkins University. She completed an internship, fellowship, and a residency in neurology at the University of Iowa. She is both certified in neurology. She has considerable expertise in clinical neuroimaging and pathological evaluation of patients with cognitive impairment and minority issues. Professor Chu is internationally recognized for her research in Alzheimer's disease and vascular cognitive impairment. I have known Professor Chu since my residency. She's such a warm and kind person. She's an old friend of Professor Liu Xiuzhi, and she's a mentor of Dr. Cai Jiafen, Wu Yude, and Li Weiru. I'm so grateful for her kind care and teaching for us. Let's welcome Professor Chu.
Thank you so much, Dr. Fu. Yes, we have known each other a long time, starting with Dr. Liu and Dr. Tang. And over 10 years, it was my honor to have Dr. Tsai, Dr. Lee, and Dr. Lin come and study with me at USC. Thank you very much for the honor of speaking tonight. Well, at noon in Taipei. So recently, Dr. Wong, my colleague, and I wrote a chapter in Continuum about vascular cognitive impairment and dementia, a review article, and I will go over some of the highlights of that Continuum article. I will talk about three things: the pathogenesis of vascular cognitive impairment and dementia, the clinical approach to diagnosis, and a brief word about current treatment strategies. So with older age, after age 80 or 90, it is very common to have mixed pathologies. Alzheimer's disease is now joined by cerebrovascular disease and in the older of old, also hippocampal sclerosis. So often vascular cognitive impairment and dementia can be mixed with another neurodegenerative disorder. We as clinicians see people and families who are concerned about memory loss and cognitive impairment, and the two most common causes are neurodegenerative Alzheimer's disease or cerebrovascular disease. And in order to try to prevent or to treat these disorders, we have to look upstream to risk factors. So for Alzheimer's disease, genetic risk factors like ApoE4 that then lead to Alzheimer pathology, beta amyloid plaques and phosphorylated tau neurofibrillary tangles, which lead to neurodegeneration and atrophy in the hippocampus and the medial parietal lobe, and then short-term memory loss, which spreads to other multimodal functions. For VCID, we look upstream at cardiovascular risk factors, which are modifiable, and hence, by treating these risk factors in midlife, we have the hope of reducing the incidence of VCID. The disease is cerebrovascular disease, and there's several major types. Arteriosclerosis includes atherosclerosis, arteriolosclerosis, and amyloid angiopathy, which actually is associated with Alzheimer's ApoE4. So cerebrovascular disease leads to what I call vascular brain injury, infarction, hemorrhages, and depending on location, disruption of various cognitive networks, and the symptoms can be quite heterogeneous. In this recent article in The Lancet, it's suggesting in midlife several types of risk factors which can lead several decades later to dementia. And I've emphasized here hypertension and diabetes. Now, the vascular tree is quite heterogeneous, and the composition in terms of the endothelial cell markers, the smooth muscle cell markers, perivascular spaces between the basement membrane of the vascular smooth muscle cell and the astrocyte on the other side. The perivascular space disappears in the smaller arterioles, and so there is no perivascular space at the capillary level, and then the perivascular space reappears on the venous side. So here's an example of the vascular tree on the arterial side, starting with Pio vessels in the meninges, then penetrating arterioles with perivascular spaces, which are very important for lymphatic drainage and circulation. And then here, intraparenchymal arterioles going into capillaries and then out to the venous side to return to the heart. And we know that atherosclerosis affects the large arteries, and hyperlipidemia and inflammatory factors accelerate atherosclerosis. Arteriolosclerosis affects the penetrating arterioles and causes hypertrophy of the smooth muscle cell. And the major risk factors are hypertension and diabetes. And this can lead to ischemia of the deep white matter and also to lacunar infarcts in the basal ganglia, thalamus, and in the white matter. Amyloid angiopathy affects the Pio arteries and the parenchymal arterioles here in an immunoperoxidase stain for beta amyloid, we can see the amyloid in the smooth muscle wall of these pial and arterioles. And the risk factors for amyloid angiopathy are apolipoprotein E4, and then there are also some hereditary forms. Now, there's various types of vascular brain injury. Infarcts I've shown here with the gold around them. And then hemorrhages I've shown here in black. And then there can be incomplete infarcts. Again, I've shown them in gold here, say in the deep white matter. And these infarcts and hemorrhages can be divided into cortical and subcortical locations, which correlate to some extent with the type of vascular disease. So large artery atherosclerosis causing large cortical, subcortical infarcts, and arterial sclerosis causes small lacunar infarcts, white matter hyperintensities, hemorrhages, and microbleeds in the deep subcortical regions. Cerebral amyloid angiopathy can affect the pial and penetrating arteries and lead to lobar hemorrhages and peripheral microbleeds. Now, in this autopsy study from Rush Religious Orders Study and Memory Project, it is interesting to see the frequency of these major types of cerebrovascular disease. Atherosclerosis, arteriolosclerosis, and important to notice how common there is cerebral amyloid angiopathy. Can you hear me okay? Okay.
Okay.
It's okay? All right. And then if there's mixed cerebrovascular disease like arteriosclerosis and atherosclerosis or arteriolosclerosis and CAA, then it's called mixed types of cerebrovascular disease. And if there's no cerebrovascular disease, this would be an average rate of cognitive decline before death. If there's a single CVD, this would be the average cognitive decline. But if there's a mixture of types of cerebrovascular disease, it predicts a faster vascular decline. So in terms of pathogenesis, I can just sum up there that if there's mixed cerebrovascular disease, there's a faster cognitive decline. And of course, if there's actually infarction and hemorrhages, there will be a stepwise decline. Now let me talk a little bit about the clinical approach to diagnosis, the exam, findings in neuropsychological testing and neuroimaging, especially MRI. And amyloid PET scans are very important now for helping us to diagnose mixed vascular and neurodegenerative causes. There's a vascular impairment classification consensus which talks about different subtypes of vascular cognitive impairment. And there's been attempts to try to develop clinical criteria. And I'll go over and review the relative sensitivity and specificity and give some case examples of these different subtypes of vascular cognitive impairment. So we have here along the left side our general evaluation history, mental status, physical exam, labs, structural imaging, metabolic imaging, and biomarkers. So here's VCID and Alzheimer's disease. And in the textbooks, we've taught that multi-infarct dementia or post-stroke dementia are stepwise with a temporal relationship between the stroke and the cognitive decline. But small vessel disease can produce a slowly progressive decline. There may be a family history of stroke, coronary artery disease, and peripheral vascular disease. The type of mental status problems will vary greatly by location of infarct or hemorrhage. But if there is a small vessel disease, the pattern tends to be dysexecutive function. The physical exam may show focal signs and gait disturbance, but the MRI will be much more sensitive than the physical exam. So we know all about associated cardiovascular changes in the eye, the carotid, the heart, and changes in metabolic markers for diabetes and lipids, and EKG changes for LVH and atrial fibrillation. So actually the most helpful thing for vascular cognitive impairment is the structural imaging study, especially the MRI. But sometimes if there's a pacemaker, we still have to go back to the CT scan. The FDG PET depends again on location. In Alzheimer's disease, I rely quite a bit on the amnestic type of memory impairment and look for hippocampal atrophy, as well as atrophy in the medial and lateral temporal, parietal, and frontal lobes. Here I find the FDG PET scan is quite helpful in showing hypometabolism in those regions with sparing of the primary motor sensory cortex. And now we are in the age of beta amyloid and phospho-tau CSF and PET biomarkers. Still don't have very helpful biomarkers in terms of blood or CSF for vascular cognitive impairment. Now at USC and in our neuropathology studies, we did look at the usefulness of neuropsychological performance to distinguish autopsy-confirmed cases of SIVD versus Alzheimer's disease. And in the neuropsychological profile, it was actually the profile for Alzheimer's disease that was most helpful. A very low lower first recall from word list learning for Alzheimer's. And in Alzheimer's, better performance on phonemic fluency than on categorical fluency. But I realize in Chinese, this doesn't really work, and I'd be curious to know if you have developed some other way of showing this dissociation. The sensitivity and specificity of these types of neuropsychological patterns, though, are not that high. The overall positive likelihood ratio is 2.57, and the area under the curve is about 0.79. So as I mentioned, the MRI is the best, most sensitive marker for vascular cognitive impairment. It is difficult to see the small micro infarcts, but with stronger Tesla magnets, that will be something that I think may become easier in the future. So here with T2 or FLAIR images, we can easily see large infarcts, lacunar infarcts, and white matter hyperintensities. And with the GRE or susceptibility weighted images, microbleeds that are in deep or peripheral locations. And it of course is when you have a large middle cerebral artery infarct, usually that'll be related to atherosclerosis or atrial fibrillation with a cardio embolism. If there's a small lacunar infarcts, that would suggest arteriolosclerosis. If there's white matter hyperintensities, that could be either arteriolosclerosis or amyloid angiopathy. Deep microbleeds would suggest arteriolosclerosis, and peripheral microbleeds, cerebral amyloid angiopathy. And I find it very important among clinical neuroscientists and clinicians to rate the severity of the white matter hyperintensity using either the Physicus scale 1, 2, and 3 or the cardiovascular health study rating scale. There are really these small 1, 2, and 3s are hardly have any neuropsychological correlates, but by the time you get out to 5 or 6, there are some mild changes in screening mental status exams, and certainly by 7 or 8, there is a slowing and dysexecutive function. So this is important, I think, to, again, the location of the microbleeds. Hypertensive arteriolosclerosis in this paper by Thal in 2003 are associated with deep microbleeds in stage A, but by stage C, they have spread from deep to peripheral. On the other hand, with amyloid angiopathy, it starts more peripherally at the gray-white junction, and then as it gets more severe, will also become deep. So they do merge and overlap with time. And it's also useful to have a semi-quantitative marker for hippocampal or medial temporal atrophy. This is the Shelton's scale, and grade 1, there's some increase of the width of the choroidal fissure, and then with stage 2, there's also a widening of the temporal horn and some slight decrease of the height of the hippocampal formation. And with grade 3, there's really loss of the height of the hippocampus, and this progresses almost to a pancake with stage 4. This actually would suggest to me a hippocampal sclerosis when it's that severe. So in much of my early career, we were developing clinical criteria for VCID, and this is a criteria from 2011 from the American Heart Association, the American Stroke Association. So I think these would be useful, especially if you're entering people into clinical trials. There's at least 4 domains tested. The decline in the activities of daily living are independent from hemiparesis or sensory loss. And there would be probable vascular dementia if there's a temporal relationship between the vascular event and the onset of cognitive deficits, or there's a relationship between the severity and pattern of cognitive impairment and the location of the vascular brain injury. If there's evidence of other neurodegenerative conditions, then that would be considered a possible vascular dementia. And then there was an attempt to say what kind of neuroimaging findings would suggest that the cognitive impairment is related to vascular cause. So 1 large vessel infarct or 2 large vessel infarcts, extensive or strategically placed single infarcts, typically in the thalamus or basal ganglia, multiple lacunar infarcts outside the brainstem, or extensive and confluent white matter lesions like a Physicus grade 3 or a cardiovascular stage 7 or 8, or a strategically placed hemorrhage or multiple hemorrhages or combinations of the above. This error in 2014 was very descriptive, and I think hopefully we'll have a better criteria in the future. Now, this is the vascular impairment of cognition classification consensus study, which was a survey of neurologists in Europe and in North America. And so here's vascular cognitive impairment and dementia, mild or major neurocognitive disorder following the DSM-5, vascular cognitive impairment or vascular dementia, and then 4 subtypes here. Post-stroke, which could be small or large vessel disease, subcortical ischemia, which is small vessel disease, lacunar infarcts, white matter hyperintensities, which and then multi-infarct dementia, which is a number of large infarcts, and then mixed vascular with neurodegenerative diseases such as Alzheimer's, dementia of Lewy bodies, or other. This is a reminder that there are some autosomal dominant and autosomal recessive genetic small vessel diseases. So here's several cases now to illustrate these different subtypes of vascular cognitive impairment. Here's a 79-year-old woman with cardiovascular risk factors and short-term memory loss. 8 years ago, she had a stroke in the distribution of the left posterior cerebral artery, resulting in a right homonymous hemianopia. But her mini mental state was 15 out of 30. Her attention was good, but her memory is 0 out of 3 because of infarction of the memory center, the hippocampus. So here would be an example of a single stroke causing a dementia syndrome. And I found this paper from Hong Kong, the Prince of Wales University, to be very interesting. There were about 400 cases after stroke, and the correlation is made between the either region of interest of the stroke and then the performance on several cognitive domains in the Montreal Cognitive Assessment. It's interesting that for the memory items in the MoCA, there was correlations with the anterior limb of the internal capsule, the superior frontal occipital fasciculus, and the inferior, this would be the superior frontal occipital fasciculus, and the inferior frontal occipital fasciculus. For language, the angular gyrus, this is left, and this is left hemisphere, this is right hemisphere. And attention and executive components of the MoCA were both associated with lesions in the anterior limb of the internal capsule, the anterior corona radiata, and you can spend some time, I think, studying these correlations. But I wanted to point out the anterior limb of the internal capsule shown here. Maybe it's easier here where it's uncolored. Here's the internal capsule, the anterior limb of the internal capsule, and the posterior limb. And the posterior limb, of course, is carrying fibers from the cortical spinal tract and descending from the vertex down toward the spinal cord, whereas the anterior limb of the internal capsule is connecting the thalamus to the prefrontal lobes. So here the fibers are going from anterior to posterior in the brain, and it's the white matter changes or infarction in the anterior limb of the internal capsule that seem very important for language. You'll see here that most of these lesions that correlate with the MoCA are in the left hemisphere, and I think that just emphasizes that the MoCA is really measuring left hemisphere functions, heavily dependent on language, and we just are not having the MoCA is not a very good scale for what's going on in the right hemisphere. So here's a second case of illustrating subcortical vascular dementia, a 76-year-old man, again with cardiovascular risk factors, and a 2-year history of short-term memory decline and decreased initiation. In 2021, the MoCA score was 19 out of 30 with attentional deficits, trouble doing digits forward or backwards, and poor memory, 0 out of 5 words, but improved to 3 out of 5 with category cueings. So not suggesting so much an amnestic or hippocampal type of memory loss, which does not respond very well to category cueing. There was slight decreased right arm swing when walking. So we have 2 MRI scans separated by 3 years, and you can see the increased lacunar infarcts here. and some progression of the white matter hyperintensities. And there is hippocampal atrophy here. Maybe certainly widening of the choroid fissure and a little bit of the, so this, it's a 1 or 2 on the MTA rating scale. So here are some key locations in the frontal subcortical cognitive behavioral circuits to note on the MRI the JNU of the internal capsule, or the anterior limb of the internal capsule, or the anterior or dorsal medial nucleus of the thalamus. So these would be the gray matter hubs in the thalamus that project through the anterior limb of the internal capsule to the prefrontal lobe. And here's a nice before and after infarction showing atrophy of the middle frontal gyrus after a lacunar infarct in the JNU of the internal capsule. So these are classic examples of strategically placed lacunar infarcts that cause BCID, SVD. So from several studies, there was an attempt to develop a simple MRI score for small vessel disease, giving 1 point for microbleeds, 1 point for 3 to 5 lacunes, 1 point for a Vesica score of 2, with a total SVD score of 0 to 3, 1, 2, 3. And then an amended score with up to 7 points, giving graded scoring for 1 to 2, 3 to 5, or greater than 6 lacunar infarcts, and graded scores for white matter hyperintensities 1, 2, and 3 for the Vesica score. And this would be a sensitivity specificity ROC curve showing in a area under the curve of about 0.76 without using this type of scores, and then better areas under the curve, better sensitivity and specificity with either the simple score of 0 to 3 or the amended score of 0 to 7. And so the overall AUC is about 0.85. And here's a case of multi-infarct dementia. That's large infarcts, large artery infarcts. This was an 87-year-old Chinese woman with cardiovascular risk factors, previous stroke. In 2016, you can see the atrophy in the middle cerebral artery territory, especially frontal, and then a mini mental state of 21 out of 30, but 2 years later, the sudden onset of aphasia, and the diffusion weighted imaging shows another infarct in the angular gyrus. So this would be an example of multi-infarct dementia. And here's an 84-year-old man with atrial fibrillation on anticoagulation, also has hypertension, hyperlipidemia. I saw him with a 1-year history of cognitive decline. It was actually a slow history of cognitive decline, but he had then multiple episodes of transient left-sided symptoms, a left facial droop, left eye ptosis, a left upper extremity weakness and numbness, and dysarthria for 10 minutes. Here we see in the GRE or scan superficial siderosis in the subarachnoid space, indicating hemosiderin from an old subarachnoid hemorrhage. And this superficial siderosis is pretty classic for cerebral amyloid angiopathy. These were left-sided symptoms, so maybe somehow related to these episodes. There was also an infarct, a hemorrhagic infarct here in the left frontal lobe. This is Flor-Beta-Peer PET scan and for amyloid, and we can see here amyloid So this is a person with Alzheimer's disease, but also vascular brain injury. So here's the Korean criteria for pure subcortical vascular dementia using certain demographics, but mostly the MRI, but using the PIB amyloid PET scan as the gold standard for whether this is pure subcortical vascular dementia or mixed. There's a large number of lacunes here, and then there's the absence of, there can be mild medial temporal atrophy, but not moderate, but not severe. Let's say not severe. So these criteria were actually have modest areas under the curve, 0.74, seem to have good specificity but limited sensitivity. And I think we are now in the age for research anyway. In the United States, these amyloid and tau PET scans are too expensive for clinical practice, but we're using them quite in our research studies. I'd be interested to hear what you're doing in Taiwan. But blood markers hopefully will help us soon with picking up the Alzheimer side of a mixed AD-VCID. So here's a couple cases where you can see confluent white matter changes. This would be the cardiovascular health study rating of 7, extending halfway through the centrum semio-valley. But there are numerous lacunar infarcts here, and the medial temporal atrophy is really quite minimal, 1. So this would meet the Seoul criteria, the Korean criteria for pure SVD, and the PIB scan does show no amyloid. Here's another case with similar severity of white matter hyperintensities, 7, but interesting, no lacunar infarcts. And I think that's an important tip, that when there's hypertensive disease and arterial sclerosis, there's usually lacunar infarcts, but that's not true for cerebral amyloid angiopathy. You'll see white matter hyperintensities, but not lacunar infarcts. And we found that in our pathology studies too. And the MTA here, though, is also not so severe, but you can see in the PIB PET scan that there's amyloid accumulation. So this person has mixed AD-VCID. And here's an individual with white matter hypertensities rated 8, very mild medial temporal atrophy, and then multiple deep microbleeds. And this is a 73-year-old female who presented with a 6-year history of seizures and then cognitive decline for 1 year. No significant cardiovascular risk factors, but a positive family history of seizures and dementia. When I saw her, her mini mental state was 6 out of 30, and she had significant impairment of executive function and processing speed. She had a slightly wide base gait, but no focal signs, and these were the MRI findings: confluent white matter hyperintensities, deep and peripheral microbleeds here, mostly deep microbleeds. And genetic testing showed a variant of Notch 3. So this was an atypical type of CADASIL. So this would be the CADASIL Notch 3 gene, and then the carousel, which is autosomal recessive with serine protease HERA1, and then the other genetic factors associated with small vessel disease. So finally, let me close with just a word about current treatment strategies. In general, the primary secondary prevention of BCID is similar to the prevention of stroke. So I think we can rely to a large extent on the society guidelines for primary and secondary prevention of stroke. For our patients, we talk about the life's simple sevens, and we've kind of added sleep now, kind of as 8, but smoking, physical activity, weight, diet, hyperglycemia, hyperlipidemia, and hypertension. And these would be some ideal definitions for our patients. And you're all pretty aware of those. And again, the American Heart Association, American Stroke Association guidelines for the prevention of stroke, and then some recent practice guidelines on the secondary prevention of stroke from the American Family Physicians. So let me pause there and thank you for your attention. And I think it's we can open for questions.
Thank you, Helena. And any question from the audience? And okay, Professor Liu has okay, not question, just a word, some word. In the line, you can see it. And okay, Wei Ru have some question.
Okay, Dr. Lee, Wei Ru.
Okay, I asked that myself. And you're saying that there is a role of ApoE carrier for the risk of VCID or mixed type dementia.
Yes, I think so, that ApoE4 heterozygote and certainly homozygote is a risk factor for amyloid angiopathy. And I think that Alzheimer's disease in this sense is a type of vascular cognitive impairment too. So I think it's artificial to separate Alzheimer's from vascular cognitive impairment. I think it's just a matter of classification. So, but in the United States, we don't have routine ApoE4 testing in clinical practice, but our families are interested in genealogy, and they can buy a saliva kit to get their ApoE genotype in their home. So sometimes our patients will come to us knowing their ApoE genotype. We're planning to start an ApoE clinic. One of my colleagues, Dr. Yassin, thinking that if we can start some prevention, good diet and exercise in midlife, hoping it might slow down the progression, but we'll need more specific, I think, therapies to prevent the deposition of amyloid in blood vessels.
Yeah, thank you.
Yes. Do you do it in Taiwan?
Yes, I'm starting to recruit some asymptomatic ApoE homozygous carrier, and to see if there is any cognitive impairment or decline in the following years.
Yes. Good.
Okay, Dr. Lin Yongxuan want to know What is your opinion on blood-based biomarkers in the discriminating Alzheimer's disease VCID and mixed VCID and the Alzheimer's disease?
Yeah, well, we're very excited about plasma biomarkers for Alzheimer's disease. So our Alzheimer's disease research centers are now in we have a national repository in Indiana, and the NIH has given administrative funding supplement to that repository so that we will be getting phosphorylated tau 181, GFAP, and neurofilament markers. They're trying to develop also validated assays for p-tau 217 and also for beta amyloid. So this is research, and we think that maybe in 5 years we'll have more validation of these biomarkers against amyloid and tau PET scans or against neuropathology, and then maybe in 5 years it will change our clinical practice. We do have, a couple FDA approved plasma biomarkers, but they're not paid for by our CMS, the Center for Medicare and Medi-Cal Services. For example, from the investigators at Washington University, some of them developed their own private company called C2N, where it costs about $1,200 to get a plasma A beta 1:42 ratio over A beta 1:40, and also an ApoE genotype. So that's FDA approved. It's CLIA approved bioassay. And so I think we're just entering that. What are your thoughts about biomarkers and how are you using them in Taiwan?
The TFDA approved amyloid beta for clinical usage, but I think it is still in study stage for most plasma biomarker.
Yes. Yeah. So, but in the future, I think we can kind of imagine, that we'll be able to classify people with these biomarkers, and that will guide, I think, some of our prevention. Hopefully we'll have some prevention for beta amyloidosis and for tauopathy, but so far nothing really that effective. So all for the future, but I think going in promising direction. It certainly will help us with diagnosing mixed AD and VCID. Right now, if there's vascular changes on the MRI, well, we treat for vascular risk factors. And even now, we say for Alzheimer's patients, we just think there's Alzheimer's, we still emphasizing cardiovascular health. But in the future, we may have a little more precise assays.
Okay, one question from the audience. Is there clinical benefit of the anticholinergic agents in the early stage of mixed type dementia?
Yes, I think if it's mixed, there would be, well, the FDA in the United States has not approved, acetylcholinesterase inhibitors like donepezil, rivastigmine, galantamine for VCID. But I think if you think there's mixed, yes, it should help, the Alzheimer component. So we do prescribe acetylcholinesterase inhibitors for mixed, and in the old studies with BINS, with the the old Binswanger label, or Cadacil with confluent white matter hyperintensities, there's evidence that the acetylcholinesterase inhibitors help a little bit with the pure VCID of that type, Cadacil.
Okay, Dr. Huang Li Kai asks, is there a role of brain perfusion imaging in cognitive dynamic and dementia diagnosis?
Yes, we're perfusion. We're not. It's mostly research that we're using it. Of course, in acute stroke, for penumbra studies, it's just a common place to decide if there's a indication for interventional thrombectomy. But in the chronic setting of VCID, we are not. We're doing it mostly in research. The perfusion studies. And how about you in Taiwan?
We use SPECT. The resolution is not as good as PET, but it is refundable for insurance, but it is not very it is not very popular in Taiwan. But I think it is helpful for the differential diagnosis of dementia.
Yes. So I also used SPECT perfusion. We used to call it the poor person's FDG glucose PET. But the pattern in SPECT and PET, FDG glucose PET, is very helpful for diagnosis of Alzheimer's disease. So if I see decrease in the the parietal temporal, like a SOC, and also I look at the precuneus, the medial parietal lobe, if that's decreased, and if there's sparing of the motor sensory cortex. So if you see a decrease in the parietal, decrease in the temporal, and also decrease in the frontal, but the motor sensory cortex is spared, that I think is very helpful regional pattern for Alzheimer's disease. So if someone has white matter hyperintensities and lacunar infarcts and has evidence of vascular brain injury, if we see this pattern on SPECT, I would say it's mixed.
Mm-hmm.
Yeah.
Okay. Wenwu has one more question. Maybe you can ask by yourself.
Okay. And is the BBB damage related to VCI? And except for the DEC MRI, is there any other MRI features can reflect the BBB damage?
Oh, well, at USC, we Dr. Betzos-Lokovic, my colleague, is an expert on blood-brain barrier, and using the dynamic contrast enhancement gadolinium with the uptake function, and then some PAT-LAC algorithms. Dr. Zlokovic and our group have been able to measure or something called K-trans, the transport of gadolinium across the blood-brain barrier at much smaller transport levels than we can see with the naked eye. Like we'll see gadolinium enhancement in acute MS lesion or with an abscess or something, but this DCE MRI is much more sensitive, can see maybe one fifth the magnitude of breakdown in the blood-brain barrier. But it's not for clinical use because it requires these input data collection and these software programs. But I think it's very important for capillary health. So that's why I kind of showed the vascular tree early on. We have measures of vascular brain injury, large cortical, small subcortical, but we don't have in just structural MRI something for capillary damage. So I think DCE is a promising way to look at it. Another way to look at capillary leakage is just the old-fashioned level of albumin in the cerebral spinal fluid. So if there's leaky blood-brain barrier, the albumin tends to go up. The other one would be looking at the eye, like fluorescein angiography for leakage of the retinal capillaries. And I think there's some work that needs to be done between correlating DCE for the brain and say fluorescein angiogram in the retina. There's Dr. J.J. Wong at USC, Danny Wong. He measures water across the blood-brain barrier, but it's a little bit different than gadolinium DCE for blood-brain barrier.
Okay. Okay, it's 1:30. Although we have 2 more questions, but I think it's very late. It's Los Angeles. Maybe Professor Liu Xiuzhi, do you want to say something? And
hello, Professor Chu. Just want to say hello and enjoy your brilliant lecture very much. Thank you.
Oh, thank you. You're so kind. Thank you.
And Jiafan, do you want to say something? You don't turn on your voice.
Oh, sorry, I forgot to turn on my phone. Yeah. See, even I'm at home to take care of my son.
Yes, is Luke?
Talk.
Is Luke there? Is Luke there?
I can call him.
Okay, because Luke was born in the United States.
Yes. This is good family education to listen your talk.
Oh, thank you. I see your name there. I miss you. Yeah, you were here with me in 2008, 2009.
Okay.
Wonderful time.
Thank you for thank you, Helena, and thank you your wonderful talk. Yeah.
Thank you. Thank you so much. Appreciate it.
Yeah.
Have a good day.
Thank you. Yeah.
Bye.
Bye-bye.
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 Bye, Weiru.